G'day. In the spirit of reconciliation, I acknowledge all of the traditional owners and custodians of all the lands that we have travelled from to be here today and indeed on the land in which we gather today. I pay my respects to their elders past, present and emerging, acknowledge ongoing and continuing contributions to land, waters and culture, and that sovereignty was never ceded. As Death Literacy Barbie and a part of this collaboration, I also acknowledge that aging is a privilege, and we do have a narrative and an expectation that end of life comes to the elderly and the older. And I also pay my respects to those who were not able to attain elder status. So now that you've tuned into my accent, I'm going to talk about end-of-life doulas and the intersection of public health as an approach to end of life. So bear in mind throughout my entire discussion today, there will be an ongoing tension because public health is macro, broad brushstroke, top down as a level. A lot of the work of end of life doulas is micro, small, grassroots, collaborative. We are starting to see the emergence of MESO, End of Life Doula UK, for example. I think Emma's got some really interesting things to say, perhaps from that perspective. But bear in mind that there's going to be large scale thinking and then very personal thinking. So from a sociological perspective, that's fun because that is public issues and private troubles, if you will. And that is not working. That's okay. We'll just do. No, that's
it does. It does. You just have to. It's yeah.
That one?
Yeah. Oh, do it up a little bit. Sorry. I wasn't. It was doing it anyway.
It doesn't like Australians.
Yeah. No, see here. Just let me try it one more time.
Okay.
Sorry.
Okay.
Well, that's frustrating.
It is frustrating because I can't get it to do this either.
Here, let me see.
Ah.
Does this now?
Okay, so here's a direct.
Now it'll work.
Yep. Here's a direct quote from the Lancet Commission into the value of death. A reductionist linear approach that fails to recognize the complexity of the death system will not achieve the rebalancing needed. By the way, my apologies. I have a shared from my loving spouse kind of sinus throat infection. So my voice is a little weird and my ears are not working properly. So I apologize. This is from the executive summary. The report was published in 2022, and this is from page 837. So another thing to bear in mind is that I will be naturally speaking often in generalities. And the thing to remember is that this is like evolution. It's not an arrow that we release and it's linear. It is like most things in life, like evolution, lots of stops and starts and different pathways and going forward and turning around and going up and down and spiraling and sometimes going backwards. So I think it's wonderful that the Lancet report itself encapsulates this so beautifully. And this is great, Dr. Annetta, but what the hell is public health anyway? So public health can most usefully be viewed. It's a top-down macro approach to enabling organized responses by governments and by society, because we have lots of government-private partnerships, we have organizations, we have committees, et cetera, to promote health, prevent injury, illness, disability, and to protect health. So what is intrinsic in this, but not necessarily explicit, is that we have a lot of responsibility on the individual in contemporary and modern public health. Public health, if we go back a couple of hundred years, was government actions to change working conditions. So think about ending children in workhouses and having shorter working days, weekends, for example, and or a physical environment to prevent communicable disease transmission. Not that any of us who've just lived through a pandemic would know about physical distancing and masking and isolation and quarantine. Contemporary public health involves both information dissemination and protocols, and then expecting individual responsibility. So when we bring together end-of-life doulas and public health has known gaps in service delivery, something that is showing up in a lot of the end-of-life doula research is the phrase filling gaps. People who fall through the gaps, we catch the people. So this is a theme and a narrative. And we know that this is a known fault in public health. Nothing is perfect. Nothing is perfect. We also don't necessarily have continuity of care, which is something that medical systems are really big on. But in fact, as your diagnosis may shift and you may deteriorate if you have a life-limiting illness, terminal illness, you don't have continuity of care with the same team or the same faces or the same people. Some of you are nodding. We know what this is like. What we have is an umbrella of general medical care, mostly, kind of, depends where you are in the world, but service approaches and people may drop in and out. The other thing that to bear in mind is death literacy, which most end-of-life doulas are really good at. We need good death literacy to get to good death competency. So congratulations, we're all working towards that. But we're also combating horrific levels of disinformation. And if you're like me and you live in a country where you have the Murdoch press, you know how bad that can be. Vaccines do not cause autism. I'm just going to mic drop that one and leave it there, for example. End-of-life doulas can support the dying in their networks in meaningful ways that support both the public health protocols and outcomes and communities in general. So end-of-life doulas actually do sit between this tension of public health and grassroots community practice, as well as general death literacy, and then in turn moving into death competency. Excuse me. The report acknowledges that diversity of end-of-life doulas and indeed for public health, death care systems overall, diversity is a priority. And here's a direct quote. I'm not going to necessarily go into both of these, but reimagining death and dying, this is somewhat significant in terms of perhaps interpreting training and pedagogy for end-of-life doula trainers, but also for those who work in the field. A realistic utopia is what the Commission has come up with. And a realistic utopia for the Lancet Commission joins reasonableness and justice with conditions enabling citizens to realize their fundamental interests. So the Lancet Commission, the report into the value of death, probably the most important, feedback's terrible. Maybe if I take that off.
Move it down.
Okay, great. Fabulous. Wardrobe malfunction. The Lancet Commission positions death, returns death, if you will, to the community, which is really where death belongs. We've had a couple of 100 years of
It just
Nope,
doesn't like
it
you.
just doesn't like me at all. We'll just, I think, maybe take this off.
Can you use the other one?
Other one? This one.
Sorry, unanticipated mic break. There you go.
Oh, I can unleash my inner drag queen.
Yes.
To gesticulate with, fabulous. Okay, so we've had a couple of 100 years of death being removed from the domestic sphere, from general public life. We have lost the understanding that death is indeed a very normal part of life. It is what happens at the end of life. Everything dies. Ask Professor Brian Cox, even the universe one day dies. So I think that even if you take nothing else away from the report, the understanding that death firmly belongs back in community and that without death, we have no life. It's a very simple baseline that the report, because very complex and interesting things have emerged from the report, but the understanding that death and life are intrinsically linked, very important. So these are the 5 sort of pathways forward to this realistic utopia of death and dying. Now, understand that as an academic, I am reading this document critically, which doesn't mean I like hated it. I'm not running with my arms up and going, I loved every moment of it either. It is the first of its kind, which means it's a very important document. We need first of kind documents. They give us a baseline as a jumping off point. It's also flawed. So you're going to hear me talk about some of the good stuff, some of the indifferent stuff, and some of the stuff that kind of boils my potato. And I acknowledge that your potato may be boiled differently to mine, and that is okay. So the social determinants of death, dying, and grieving need to be tackled. Social determinants are really basic things that are so important, we tend to forget that they're there. Are you wealthy? Are you impoverished? Did you have housing security when you were young? Actually impacts the trajectory of your health over your lifespan. Are you comfortable now? Have you had access to proactive healthcare? Are you a migrant? Are you disabled? Are you queer? Are you, unlike me, speaking with a funny accent so people treat you differently? That matters. So bear in mind too, your social determinants of health, or your SES, your socioeconomic status, is also going to be on a gradient and vary depending where you are in the world. So it's not just your position in society as such, it's your position. Are you in a developed country? Are you in a developing country? Are you in a global majority country? Okay. Dying is understood to be relational and spiritual process rather than simply a physiological event. I have a real issue with this, and I'll go into that one a bit later on, because not everyone thinks spirit is any part of dying. And this excludes and marginalizes and invisibilizes anybody who doesn't have a religion or a spiritual baseline. Networks of care lead support for people dying, caring, and grieving. Yes. So this is where the link to compassionate communities, compassionate neighborhoods, compassionate cities, and yay, Taiwan, compassionate countries. And end-of-life doulas are often right at the heart of that and in the thick of that. Conversations and stories about everyday death, dying, and grief become common. So language matters, and the report does in fact acknowledge this and does it very well. And this is part of the reclaiming and the normalizing. This is how we get to the death competency, because this is about death literacy. And that death is recognized as having value. Death is not an enemy. Although try telling that to medical doctors, because we have positioned them after centuries of making them experts as being the ones who will not let us die. Everything dies. It's very hard to have that conversation in California, by the way. That one's always, if you're ever going to be on the west coast of the USA, go to California, try and talk to them about an absence of immortality as being part of humanity, and watch their heads explode. Now, the Lancet report does address end-of-life doulas. The death doula movement is an attempt to build skills and capacity relevant to death within communities. Now, that may be a little bit bare bones for some of us, but that's actually a pretty neat encapsulation. This is a response to the fact that we have, as Bernard Salt, the Australian commentator, put it, a freight train of death coming, because boomers, and we're not staffed or funded or infrastructured for people to keep dying in medical environments. So we are, as Marion has put it so eloquently, dying differently. And end-of-life doulas are arguably a response to that. Okay, so this also talks about how one of the best things that death doulas can do is support people not only in conversation, but in advanced planning and understanding their rights, options, and choices at end of life. Very important. Right, the death doula movement, which operates in many countries, has a specific aim to bring dying home in our communities, as we believe it is all of our business and not the sole preserve of experts and professionals. Remember the 95 and 5. When we're at end of life, we are spending 5% of our time parked in front of a medical professional. 95% of our time is lying in a hospital bed, sitting in an armchair at home, being in bed at home, being around friends, family, if you're me, pets, if you're a friend of mine, houseplants, everybody's different. 95% of our time is not with medical experts. This is a huge gap that community building and end-of-life doulas can help fill. So again, more evaluation is needed to understand how these approaches challenge and reform current experience and practice. Yes, right. The social determinants of health, I'm just going to quickly breeze through the next few slides. But one of the things that comes up that really works my potato is that volunteerism seems to be a built-in baseline for a lot of end-of-life care, which then, okay, women are doing that. Newsflash, any of you who missed the patriarchy, women are paid far less than men. In Australia, for example, the #1 group at risk of homelessness is women over the age of 60. Being able to volunteer is a privilege. It is a privilege of wealth, and it is a privilege of status. It also burns carers out. It also sometimes does funny things to power and siloing information. So the culture of volunteerism, I think, needs to be really scrutinized and borne in mind. Cultural change also takes time and persistent effort. We are probably looking at a generational change. It's not going to happen overnight. As the report itself acknowledges, and as does, for example, people like Dr. Julian Abel and Professor Alan Keller here, it's not a one-size-fits-all situation, which is why I spent some time talking about, where you are in the world, and everything is relative. Diversity within the end-of-life doula arena, said the highly educated white woman who was able to get on a plane and deal with insurmountable jet lag. And what a privilege. I get to travel internationally and wave an accessory. I am the face of a lot of the problem for the absence of diversity in end-of-life doulas, and I acknowledge that. However, there are all sorts of avenues and organizations and groups working to address this. And we're also seeing a rise of training outside of the USA, Australia, UK, and Canada. So another thing with the social determinant is voluntary assisted dying is not universally available across countries. And this is something that does play quite a role in terms of being a social determinant of health, whether or not you then in the end, if you qualify, choose to access assisted dying or not. Lots of people don't. They are approved or they get the medicaments. It's having the choice. So this is something for quality of life and end of life and mental health that's actually incredibly important. And I know that that's an ongoing debate here in the UK at the moment. Part of the issue there is misinformation about palliative care and pain relief. But we have good palliative care. We've actually seen VAD, and my head's a bit stuffy, so I can't remember which country it was, but I think it was last week or the week before, a judge said, but no, we have good palliative care. We don't need assisted dying in this country. Tell that to the at least 5% of people for whom pain relief doesn't touch the sides. End-of-life doulas have to be aware that, yes, working with palliative care is essential, but some people don't get any pain relief. So you also need to be aware that you need to manage your own healthy self-care and your own burnout really effectively. Dying is understood to be relational and spiritual rather than simply physiological. Community is emphasized in the report, and this is a really important touchstone. Death outside of mainstream norms remains a point of resistance and friction, which is sometimes problematic for multicultural communities. But at the same time, it's also harder for funeral corporations to co-op. There's a lot of money in death. If you're going to be an end-of-life doula, you also need to realize that funeral companies are going to have some views. The spectre of Dame Cicely Saunders and her very, very powerful Anglican faith influences hospice and palliative care to this day. And in fact, the report echoes this. So there is a presumption of belief as a universal. Please understand that this is often something that happens no matter what the religion of a country or a place is. So we get this with the Buddhist religion and with the Islamic religion and Jewish religion, where we find these as being quite influential in terms of government or cultural practices. But speaking as an atheist and rationalist who does work with a lot of people of faith, that doesn't work for me. And I find it deeply problematic that belief is, I mean, St. Augustine is actually referenced in the report. Now, St. Augustine is the man who had real issues with anorexia, loathed his body, really hated women's bodies. So just be aware that religious faith and spiritual practice, while being very, very important for individuals, don't make assumptions. And double check your own language and practice. There's also a link between particularly Christian faith and colonization. So if you look at Rudyard Kipling's The White Man's Burden, for example, Christianity and whiteness would seem to be the answer for and a justification for slavery and colonization. So you may be working with people who have that in their ancestral and familial backgrounds. There's also pronounced emphasis on suffering in general. So this can be problematic because, particularly from a Buddhist perspective, what's the metric for suffering? Why do we all have to go through that? You're not taking into account people who may live with multiple disabilities, comorbidities, people who experience pain generally. So this is also affecting women more than men because we tend not to believe women in terms of pain, but also global majority. If you've got more melanin in your skin than some people, your pain is always minimized. Have a look at some of the statistics in the USA for childbirth and endometriosis. Black women are often not offered any pain relief at all. But white women will be offered pain relief before they're sent home. Networks of care lead support for people dying, caring, and grieving. Volunteerism and family cultures can play a part here. If you're told to only interact with the oldest daughter or the youngest daughter, which depending on global cultures, that can be quite common, that's putting an unfair burden of care. We also tend to expect that spouses are going to do it all. So primary care burnout, particularly spouses, is a global public health priority. So the WHO is looking at that specifically. We also have the intersection of medical doctors and the expectations that we can put off death forever. Now, sometimes this is an incredible burden that we place on medical practitioners, which is deeply unfair to them. But that's also the culture, which means doctors themselves are kind of like, well, I have to put my knickers on outside my tights and a towel around my neck, and I got to save everybody because that's my job. And that's a cultural shift that's going to take time. So there may be some resistance to end-of-life doula work that is tied to this. Public health kind of has to be a little bit of a flying nun, which means people can get cut off or left around the edges. So poorer people, homeless people, migrants, refugees, queer people, people with disabilities. So I think it's also worth bearing in mind that Ruth Coker Burns, during the AIDS crisis, in a sense, pioneered the modern end-of-life doula work. She sat with young men dying of HIV/AIDS when no one else, sometimes in hospitals, would even go into the room. So companioning and witnessing is not just something that's happened very, very recently this century. There are some antecedents that reach back. Conversations and stories about everyday death, dying, and grief become common. And I really think this is one of the greatest strengths of the Lancet report, is the emphasis on returning death to the public domain. And end-of-life doulas have the capacity and position to support community and individual remembering of death, dying, and the griefs that come both before and after death. So I myself am a grief practitioner. I have 35 years of experience in grief, loss, and trauma and injury. So I take this really seriously, and I'm really impressed that this is here and articulated so beautifully in the report. As I mentioned earlier, but it bears saying again, because language really matters. The report also correctly identifies language in advanced planning and end-of-life discussions as needing to change. I use the word important. Dr. Catherine Mannix here in the UK uses tender. Here in the Lancet report, I think it's very nice, they say essential. They're not hard or tough, because we don't do the hard and tough stuff, but it is essential. It's essential that we have these conversations. And end-of-life doulas are often at the forefront of using non-euphemistic language, of promoting and facilitating and maintaining conversations about end of life. And we model good death literacy for clients and community alike. And often, death cafes and information events are being run by end-of-life doulas. Now, death is recognized as having value. No surprise, it's actually in the title of the report. There's no need to continue to hide death away as something vague, threatening, and arcanely mysterious. The very day-to-day normality of death brings death back into the spectrum of life. And allows everyone to participate, question, explore, feel, and experience both the banality and the definitiveness of end of life and death. This encourages options and stories, memories, and ideas, and this works right from our elders all the way down to young children who might just like, what's a funeral for? Give them a sentence or two, and they'll run off and be really happy, but then they'll come back when they've got more questions later. Value permits communities to understand and embrace death more openly, to grieve and more completely and faster, and frees medical professionals from the shackles of limitless life as an attainable and indeed a desirable idea. So, a couple of things to bear in mind. Discussions around the good death, which often gets co-opted as being, well, you must do this. And that's very performative and can actually detract. Yeah, thank you, TikTok and Instagram. My death will not be TikToked, or I'm going to go against everything that I think and track you down and haunt you. Let's take the performativity out of it. I support the idea of a good death when I'm having a conversation and I ask a client or a community group, what is your idea of a good death? Because that's what it comes down to. It's not quantifiable. That's not a one size fits all. And the report does go into discussions of ways of having death, doing death, thinking about death in different countries. There are 22 authors in this, and there is cultural diversity. So there's a lot of really rich food for thought. I think never ignore fresh knowledge. And even when you might have a really good idea and understanding of how you do what you do and why you do it and say it, the report has a lot of meat that can perhaps help your own self-understanding or even offer ways of discussing things more fully with community and clients. One thing that really, oh, my potato is not happy at this point. Helen Kubler-Ross is really misquoted. There is a misunderstanding generally that the 5 stages of grief, remember we're back to the linear arrow, which doesn't exist. That's not about people processing the death of someone they know. That was developed to help people come to terms with their own diagnosis. There is a huge difference. As a grief practitioner who's also an end-of-life doula, I keep that work often very separate for that reason, because if you know a little, you can do a lot of harm. So Kubler-Ross is really useful, but we don't necessarily go through those 5 stages, and it's certainly not, well, you do this, and then you do that, and then at the end, there's a little chocolate medal, and someone will wave a flag because you've done it. We don't graduate grief. As we all know, grief is often lifelong and varies. So please honor Kubler-Ross by using her work appropriately and try and correct the myth gently. I mean, if you need to put someone in a headlock to do it, that's okay. Just don't do it in front of witnesses, all right? Okay, Another issue to bear in mind, now this is general contextual, is money, money, money. The funeral business is big business. I come from a country of about 27 million people, and death is $3 billion a year. The funeral industry has a lot invested in people not knowing rights, options, and choices. There can be extraordinary pushback from funeral organizations, which is not your independent funeral celebrant and director, by the way. And also there are many, many more options for burial here in the UK than we have in a country like Australia, for example. But it's the economic drivers of the social, including public health, bear it in mind, because in Western Australia, the funeral directors as an organization got together and lobbied the government and successfully got the administrative paperwork for having a funeral at home. But yeah, that's the face, yes. And it's a very small window. The paperwork is deliberately very arcane and complex. And as a result, home funerals don't happen very often. Yeah, so just bear in mind, money's there. Okay, things to bear in mind. Palliative care can be either for or against end-of-life doulas. Work with it, go with it, do what you can, be the water on stone. Both top-down and grassroots. That's a matter of education and patience and networking. Information changes rapidly. Read Marin and our report when it comes out, for example. We do need to stay well informed. Specialist and generalist pathways can work for end-of-life doulas. I know people that only work with pets. Some of us work with infant loss, elderly death, cancer. So you can be a generalist, you can be a specialist. It's okay, do what you do. And in-person isn't always the best solution. I do an awful lot of work online. So embrace the idea that maybe somebody has social anxiety and really doesn't want to meet you in person, but they're happy on the phone, or yes, nodding enthusiastically. Some of us are practitioners, live with disabilities. You know, we like to work online. There's space for everybody. But fundamentally, and at the end-of-life doulas, I contend, may be able to support and facilitate the best possible quality of life at end of life. Right. To identify the most pressing issues in science, medicine, and global health, with the aim of providing recommendations that change health policy or improve practice. That's the core tenet. That's the mission statement of all Lancet reports. If you would like to access the value of death, there's your QR code. It's here all week. Try the chicken. Oh, I apologize. I misspoke, 27 authors. It was published in 2022. That's where I mixed up my numbers. There you go. So you'll have access to these slides. You can scan it. You can also just Google Lancet report value of death and bingo, there you go. It's very, very well laid out. It's clear. It's got a menu so you can jump around in the document, or you can read through it as you like. I don't know your life. And there you go. There's some references. I didn't want to bore you with about 10 slides. So if you would like more in terms of references, email me. You know, I enjoy a little light cyber stalking in the afternoon. You can probably track me down online, but I'm happy to share resources. Thank you.